Good evening and warm welcome to each one of you on behalf of Alchem Metabolics team. My name is Dr. Mayur from the medical team of Alchem. Welcome you all for this DAPANORM conclave today, changing the treatment landscape in diabetes and heart failure management. Indeed, this drug is actually changing the landscape and it is taking the management of diabetes and heart failure to the different level with the different mechanism of actions proven over multiple years. Today, to decode this topic, we have next 90 minutes power-packed sessions followed by esteemed faculties. This is the today's agenda of the meeting. After setting the context, we will learn about new data and therapies of changing the treatment landscape in management of diabetes and heart failure, followed by sacubitril valsartan, a large clinical trial to clinical practice, followed by the session on redefining the role of SGLT2 inhibitors in heart failure, and followed by a session in new normal therapy in diabetes, dapagliflozin, and followed by the question answer sessions and vote of thanks. Now, it is our privilege today to have Dr. Professor Scott Solomon with us. Welcome, sir. And we are actually privileged to have you today with us. To introduce himself, he actually doesn't need further introduction. He's an Edward Frawley Distinguished Chair and Professor of Medicine in Harvard Medical School and Director of Clinical Trials and Outcomes in Boston, Massachusetts. His research work interests have focused on cardiac failure and function and multiple modifiers of risk and heart failure management and cardiovascular outcomes. He is renowned clinical research trialist for two important trials in dapagliflozin, with respectively Paragon HF and Deliver trials. And he has published more than 950 peer-reviewed articles in different journals. And he's the author and editor of Grunwald Heart Disease, a textbook of cardiovascular disease. Welcome, sir, and looking forward to hear from you in next few minutes. Today, to moderate this session, we have privilege to have Professor Dr. Krishna Kumar, sir, as a moderator. Welcome, sir, and thank you so much for joining us today. He's a senior consultant intervention cardiologist in Trivandrum, having more than 2 decades of clinical experience. He's a professor at Government Medical College in Trivandrum. His special interest areas are coronary interventions and peripheral diseases. And he's given lectures in many national and international conferences at numerous forums. Welcome, sir. We have 3 esteemed speakers with us today. We have Dr. Rajiv Agarwal, sir. He's a consultant cardiologist from Meerut, and he chairs the Department of Cardiology at Jaswant Rai Specialty Hospital in Meerut. He has awarded multiple accolades to his credit. Just to name the few: Amar Ujjwala National Excellence Awards in 2017, Inspiring Doctor India Award Cardiology by Economic Times in 2018, and Life Literacy Excellence Honor in 2018 by Bharat Nirman. He has given multiple orations across various conferences and has publications to his credit. Dr. Rajiv, welcome, and thank you so much for joining us. Next, we have Dr. Anurag Sharma, sir. He is a consultant cardiologist at the Department of Cardiology, Ojas Hospital in Chandigarh. He has performed more than 3,500 PTCAs and more than 5,000 coronary procedures in different subgroups in these population. He's a gold member of Heart Failure Society of Europe and life member of Heart Failure Society of India. He has many publications to his credit, and he's a co-investigator for a WAVE registry here. He is helping many needy patients of poor economic class through his NGO Kamala Devi Memorial Society in Chandigarh. Welcome, sir, and thank you so much for joining us, and looking forward to hear to you. And last but not the least, we have Dr. Mayur Agarwal, sir, endocrinologist at Hormone India Diabetes and Endocrine Center in Bhopal. He's a gold medalist during his medicine tenure, and his research work on Sheehan syndrome and Addison's disease is extraordinary. And he has authored many chapters in various books and textbooks. He has launched the Diabetes Reversal Mission with DocPlex in India, and he has given many lectures at national and international forums in different topics. Welcome, sir. And again, thank you so much for joining in for us today. Now, with this small, brief introduction of all our speakers, a moderator, and our international speaker, I will now hand over a session to our moderator, Professor Krishna Kumar, sir, and request him to take over the proceedings, please.
Yeah, good evening to all. I think good morning, Professor Scott Solomon in the US. So it's a landmark day, or it's a historic day for India, especially for the common heart failure patients in India, because yesterday, I think ARNI, that is Sacubitril Valsartan, has been become more or less generic in India with court verdict. So I think the common people, common heart failure patients in India can afford this drug like anything from I think within a week's time. And the beauty is that SGLT2 inhibitors, that is very costly in the Western or in outside India, especially in Europe and US, that's also become generic in India. So according to, I think I had the fortune of, I think Professor Scott Solomon doesn't know that I had the fortune of having a part of the ASPIRE study, that is aliskiren post-MA remodeling, I think in 2005 and 2006. I was a co-PA in echocardiogram sub-study in Trivandrum. So at that time, and I was using this ARNI like anything from 2017 onwards. I think 2014 it is Entresto was become available in US. So I had the observation that ARNI, when using ARNI, after some time, within 3 to 4 months, patients became very much younger, at least 10 years younger. So I had the same feeling. Then after 2 or 3 months, when I have seen the literature, JAMA Cardiology or JAMA, Professor Scott Solomon has written, patients look 10 years younger after using ARNI. So that was a very revealing information. So for me, ARNI and SGLT2 inhibitors are like, it's a very paradigm. It's a groundbreaking or a landscape, landmark drugs in India. So Indians are very fortunate in having ARNI, and SGLT2 inhibitors are affordable at a generic cost. So without much further ado, I think I invite Professor Scott Solomon to deliver his oration.
Well, thank you. Yeah, thank you very much. And it's a real pleasure to have a chance to talk with you today. And for me, it's a Saturday morning. I know it's evening for all of you, but it's really an honor to be here with you at this meeting. So today I'm going to talk about the treatment of heart failure with mildly reduced and preserved ejection fraction, where we are in 2023 and beyond. And this is an area that I've been studying for the last 20 years, and I'm so delighted that we've finally been able to make some headway, some real progress to help our patients with this type of heart failure that we've really not had good therapies for in the past. Here are my disclosures. And let me just remind everybody that if we go back to only 2016 and we look at the most recent clinical practice article in the New England Journal of Medicine on heart failure with preserved ejection fraction, we can see that all of the therapies that were discussed were essentially empiric. There were no targeted evidence-based therapies at that time for heart failure with mildly reduced or preserved ejection fraction. We'd made lots of progress in heart failure with reduced ejection fraction, as you all know, but in patients with an ejection fraction of over 40%, we simply did not have evidence-based therapies. Now, that wasn't for lack of trying, because for many years, we tested the same therapies that we've been using in heart failure with reduced ejection fraction for patients with heart failure with preserved ejection fraction. And these were primarily renin-angiotensin-aldosterone system inhibitors. And these were tested in the CHARM-PRESERVE study, the ARB candesartan, PEP-CHF, the ACE inhibitor perindopril, I-PRESERVE, the ARB irbesartan, and then in the TOPCAT trial, the mineralocorticoid receptor antagonist spironolactone. None of these made their primary endpoint. Some came kind of close, I have to say, but none of them made their primary endpoint. If you do a meta-analysis of all the RAS inhibitor studies, as is shown here on the right, you can see that there is a modest but significant, about 11% reduction in cardiovascular death or heart failure hospitalization. So there's some biologic activity there, but it isn't enough, I think, to determine that this is the way to treat these patients. Well, we learned a lot from these early studies. One of the things that I think was most elucidating was that if there was any benefit to being on RAS inhibition in TopCat, that was the mineralocorticoid receptor antagonist spironolactone, and in CHARM, it was the ARB candesartan. If there was any benefit, that benefit was greatest in the patients with heart failure with an ejection fraction in that what we now call mildly reduced range, between about 40 and 55%. We can see that the treatment effect there is greater than it is when you get up into the higher ejection fractions. That was true in the TopCat trial, and it was true in the CHARM trial. Very similar patterns. So this reduction in benefit as you go into higher ejection fractions. Well, as you know, we have been testing sacubitril valsartan for many years now. I was involved in the original studies, of course, with sacubitril valsartan as a member of the executive committee on the Paradigm HF trial. And of course, sacubitril valsartan is a drug that both blocks the renin-angiotensin system through valsartan, blocks the AT1 receptor, and also the neprilysin inhibitor blocks this enzyme neprilysin that is responsible for the breakdown of the biologically active natriuretic peptides like ANP and CNP and BNP. And when you give this drug, you're blocking the renin-angiotensin system. At the same time, you're augmenting the naturally occurring vasoactive peptide system. And of course, we showed in the Paradigm trial significant and very robust reduction in cardiovascular death and heart failure hospitalization. Cardiovascular death alone, all-cause mortality in patients with heart failure with reduced ejection fraction. Okay, well, at the same time, we did a pilot study in heart failure with preserved ejection fraction called Paramount. And then we went on and did this trial, Paragon HF, which is a trial of heart failure with preserved ejection fraction. We enrolled people with an ejection fraction of over 45%, elevated natriuretic peptide, structural heart disease, and we randomized them either to sacubitril valsartan or valsartan. And we did randomize them to an active comparator, valsartan, and the reason for that was that many of these patients are already on RAS inhibitors. So as you know, when we did this, our primary endpoint was total heart failure hospitalization and cardiovascular death. I presented these results 3 years ago at the European Society of Cardiology, and we saw a 13% reduction in total heart failure hospitalizations and cardiovascular death that was just short of statistical significance, as you can see over here. But there was ample evidence that there was substantial biologic activity going on here. We saw improvement in New York Heart Association class, net improvement in New York Heart Association class. So patients were more likely to have their NYHA class improved, and they were less likely to have it worsened. We saw greater improvement in a measure of quality of life, the Kansas City Cardiomyopathy Questionnaire. And we saw that patients had a 50% reduction in a composite renal endpoint of renal death, end-stage renal disease, or a 50% or greater decline in eGFR. So reasons to think that there was real biologic activity going on here. And then we saw something very interesting, which is essentially the exact same pattern we had seen with TopCat and with CHARM, which is that the benefit was absolutely the greatest, and if you will, almost restricted to the patients with lower ejection fractions in this trial. So our median ejection fraction was 57%. And if you were above that median, there was attenuation of benefit. But if you were below that median, we saw pretty substantial benefit, as you can see over here, with hazard ratios that are similar to what we saw in the Paradigm trial. So now if we put together the data from Paradigm and Paragon, we see that sacubitril/valsartan did have a significant treatment effect in both trials up until an ejection fraction of about 60%. It's a little bit different for men and women. Women derive benefit to a higher ejection fraction than do men, which is, I think, very interesting. And so we saw the same pattern that we had seen with the other trials as well. Well, we took this data to the FDA in the United States, and there was a 12-to-1 vote by the advisory committee to approve the expanded indication for sacubitril/valsartan. And this is now the indication in the U.S. and, as you know, in many other countries as well. About 25 total countries now have this expanded indication. Well, we've also estimated what would be the benefit in our patients who have really been waiting for appropriate therapies for these patients with heart failure with mildly reduced and preserved ejection fraction. And we estimated this in this publication in JAMA Cardiology from my colleague, Dr. Vadaganathan. And you can see here that we've estimated that up to about 1.8 million people in the U.S. Would be newly eligible for sacubitril/valsartan based on where you put that cutoff. And the FDA did not specifically say what ejection fraction cutoff they would use. They did say the benefit was greatest in patients with lower ejection fraction. And that would lead, we believe, to as many as 180,000 fewer heart failure events. So this really does translate on a societal level as well. Okay, I'm going to turn my attention now to the other class of drugs that we wanted to talk about today, which are SGLT2 inhibitors. And of course, you're very familiar with SGLT2 inhibitors, their mechanism of action and so forth. They're drugs that were originally developed for the treatment of diabetes. They are therapies that block sodium and glucose transport. And of course, we see that patients taking SGLT2 inhibitors, when their glucose goes above a certain threshold, they will spill glucose in their urine. This is obviously the reason that it was originally developed for diabetes treatment. But lo and behold, we found in early trials that there was a significant reduction in heart failure hospitalizations in patients with diabetes who were being treated with SGLT2 inhibitors. And subsequently, we went on to test dapagliflozin in a patient population with heart failure in the DAPA-HF trial. And as you know, DAPA-HF showed significant reduction in the composite endpoint of cardiovascular death or heart failure event in patients with established heart failure. That was the first trial to show a benefit in heart failure, specifically with an SGLT2 inhibitor. So fast forward a few years, and a year ago at the ESC, the Emperor Preserve trial was presented with empagliflozin compared to placebo in patients with heart failure with mildly reduced or preserved ejection fraction, EFs over 40%. And as you can see here, there's a 21% reduction in the composite endpoint. This was driven primarily by heart failure hospitalization. There wasn't a significant reduction in cardiovascular death. Well, there have been a number of questions that came up after the presentation of Emperor Preserve, and one of which was there also that attenuation of benefit that we had seen in CHARM and TOPCAT and in Paragon as you go into the higher ejection fraction categories? There's certainly a hint of it when you look here. And if you look at the data in slightly different ways, as published in a number of different forums by the Emperor investigators, you see that there appears to be attenuation of benefit as you go into the higher ejection fraction range over here and over 65% over here. There doesn't seem to be much of a benefit. And so this question remained. And so we had some questions about SGLT2 inhibitors even after Emperor preserved. There was unequivocal benefit in heart failure with reduced ejection fraction. Emperor preserved did show benefit in heart failure with mildly reduced or preserved ejection fraction, but was there attenuation of benefit in the highest LVEF range? Was the benefit also apparent in patients who were hospitalized or recently hospitalized? And this is a group of patients that were not included in Emperor preserved. And then finally, what about patients who had prior left ventricular ejection fraction under 40% that had improved to over 40%? This is a group we call heart failure with improved LVEF. And this group of patients has been excluded from all prior outcome trials. Well, we were really well poised to answer these questions with the DELIVER trial. And DELIVER enrolled patients who were 40 years of age or older, heart failure, New York Heart Association class 2 to 4, LVEF over 40%. And we included patients who had a prior LVEF under 40% that had improved. They had to have structural heart disease, elevation in natriuretic peptides, and could either be ambulatory or hospitalized for heart failure. Patients were randomized to dapagliflozin or placebo, and we ended up randomizing 6,263 patients. So this is the largest heart failure with mildly reduced and preserved ejection fraction study. And the median follow-up was 2.3 years. At the end of the study, we had vital status on all but 2 patients in each treatment group. Baseline characteristics were well balanced between groups and completely expected for patients with heart failure with mildly reduced or preserved ejection fraction. Their average age was 72. The baseline ejection fraction was about 54%, and 44% were women. The majority of our patients were New York Heart Association class 2. You can see elevation in natriuretic peptides. 44% were diabetic patients. And then the medications they're on were typical of these patients. About 77% were on loop diuretics. 5%, interestingly, were on sacubitril/valsartan, and about 42% on mineralocorticoid receptor antagonists. Well, here are the primary results of the DELIVER trial, which I'm sure you've now seen. We saw a greater reduction in worsening heart failure or cardiovascular death, which was our primary endpoint in the dapagliflozin group, with a hazard ratio of 0.82, highly statistically significant number needed to treat of 32. And this was also, just like Emperor preserved, mostly driven by worsening heart failure. We didn't see a significant reduction in cardiovascular death, although it was reduced by 12%. This doesn't bother me because in patients with heart failure with mildly reduced and preserved ejection fraction, their event rates for cardiovascular death are relatively low, especially compared to HFrEF. And we would have had to do a trial that was twice as large or twice as long to be able to see a reduction in cardiovascular death. Here you can see all of the endpoints in all of our patients and patients with an LVEF under 60%. And then, interestingly, in the patients with an LVEF over 60%, which made up 30% of our population, we see no hint of attenuation of benefit. So unlike what was seen in Emperor Preserve, we see no hint of attenuation of benefit as you go into that higher ejection fraction category. And that's true for worsening heart failure. It's true for cardiovascular death as well. And then if we look at specific groups that we're interested in, here's left ventricular ejection fraction. And again, we see whether you're in the under 50% range, or 50 to 59, or over 60%, the results are really very much the same. Again, no attenuation of benefit as EF goes up. Now look at the patients who were enrolled either during or within 30 days of a heart failure hospitalization. And you can see here, this is about 600 something patients, about 10%, 11% of our patients. They benefit at least as much as the patients who were enrolled later. And then look at the group with improved ejection fraction with a prior LVEF of 40% or under, that had improved by the time of enrollment, and they derive as much benefit as patients who had an LVEF that was consistently over 40%. Our first primary secondary endpoint was improvement in Kansas City Cardiomyopathy Questionnaire, total symptom score, and you can see here that this was reduced. I'm sorry, this was our second primary secondary endpoint, but this was reduced by 2.4 or improved by 2.4 points in patients receiving dapagliflozin. And we see a greater proportion of patients with a 5, a 10, a 15% improvement in the KCCQ if they were taking dapagliflozin, and a smaller percentage of patients with a 5-point worsening if they were taking dapagliflozin. We also saw that New York Heart Association class, which didn't modify the original treatment effect, we saw that there was improvement at 4, 16, and 32 weeks in patients receiving dapagliflozin. We also see that if we now pool the data from DAPA-HF and DELIVER, again, very large numbers of patients, about 11,000 patients here, we see the cardiovascular death overall is reduced by 14%. And importantly, when we look across the full spectrum of ejection fraction, we see no hint of heterogeneity. In other words, this is the hazard ratio. It is essentially flat. And although we have fewer cardiovascular deaths at the high end of the ejection fraction spectrum, we have the same overall treatment effect across the spectrum. The same thing is true for all-cause mortality, which is reduced by 10%, again, statistically significant overall in this very large group of patients. And then there is no heterogeneity across that spectrum. So if we now put together the data from DELIVER and EMPEROR Preserve, we can see we gain power. We have a 20% overall reduction, almost identical point estimates, 20% overall reduction in a composite of cardiovascular death or first hospitalization for heart failure. And then when we look at cardiovascular death, we see a 12% reduction overall. And now, since we have more power, we have a p-value that just is borderline 0.052. So you can see this really is about power when we talk about cardiovascular death in this population. And if we now put the data together from EMPEROR, Preserved, and DELIVER and look at those categories of ejection fraction that I told you about before, we see that we essentially even things out, although there did appear to be some attenuation with EMPEROR, Preserved. When we put these together with DELIVER, we basically see that it looks very flat across the spectrum of ejection fraction, suggesting that there is benefit as you go into higher ejection fractions. Now, what about this very important group of patients with heart failure with improved ejection fraction? Again, this is a group for which we've had very little data because they've been really excluded from most other clinical trials. And here we see that these patients showed a significant reduction, 26% reduction in the primary endpoint receiving dapagliflozin, and even cardiovascular death was reduced by 38%. This is a subgroup, so we have to be somewhat circumspect about these results, but it certainly is intriguing. We've recently published these data in Nature Medicine, and we can even see that the patients benefit regardless of what, regardless of whether they were in any number of pre-specified subgroups. But importantly, even the patients whose ejection fractions ultimately ended up greater than 60%. So they had recovered or improved from under 40% to over 60%. They still derive benefit from being placed on dapagliflozin over here. Very important. Now, we've also seen that the benefit of this therapy happens very, very early. Within 30 days, we see a highly significant reduction. In fact, our first time to clinical significance in this trial was about 13 days. Really impressive. It works very quickly. Here you can see the hazard ratios at various times in the trial. What this tells me is that we should be using this drug as soon as we can, because if we delay, then we will be putting our patients at increased risk. So I'm going to end by just telling you where I think we are in the pharmacologic treatment of heart failure in 2023. Obviously, in HFrEF, beta blockers have become standard of care. Originally, ACE inhibitors and ARBs were standard of care, but I think we all agree now that sacubitril/valsartan should be used instead of ACE inhibitors and ARBs in the majority of patients. And it's great to hear that you can do that at relatively low cost in India as well. Mineralocorticoid receptor antagonists, obviously very strong data in heart failure with reduced ejection fraction. We should be using it. There's some data from the TopCat trial in heart failure preserved ejection fraction, but that data is not as strong, obviously. And so some patients are treated with MRAs when you get up into the 40% to maybe 50-55% range. But clearly above that, we see attenuation of benefit. The only therapy that is proven to be beneficial across the full spectrum of ejection fraction in heart failure is SGLT2 inhibitors. And I think that at this point, we now believe that SGLT2 inhibitors should be foundational therapy in patients with heart failure, irrespective of ejection fraction or care setting. So I'm going to end here and be happy to take your questions. Thank you so much for your attention and allowing me to speak today.
Professor Scott Solomon, that was a wonderful overview of the new and emergent therapies in heart failure. I think we will be on to the question. I think just chat box. Any questions, Swapnil, Mayur? So because I will start the question by asking a question doubt regarding this thing. See, regarding quality of life thing, because I have been using this SGLT2 and ARNI, I think for the last so many years. And I found that ARNI is much more producing much more quality of life. But most of the doctors are of the different view. So what's your view regarding the quality of life versus ARNI vis-a-vis SGLT2 inhibitors?
Yeah, I think you're right in that patients, when they start taking an ARNI for whatever reason, and I'm not sure I know why, they feel better very quickly. It's fairly rapid. And so you're going to hear that as a physician. I also think that SGLT2 inhibitors are associated with improvement in quality of life. And we also showed that in the DELIVER trial, but it probably takes a little bit more time. My sense is that it happens over a longer period of time. I think these therapies are both foundational in the right patients. Certainly in HFrEF, we should be using ARNIs without question. They are disease-modifying therapies. They reduce cardiovascular death very robustly. None of the SGLT2 inhibitors in HFrEF also probably reduce cardiovascular death, but it hasn't been as robust as sacubitril/valsartan in the PARADIGM trial. But we should be obviously using both of these therapies in those patients. In HFpEF, or heart failure with mildly reduced and preserved ejection fraction, I'm convinced that sacubitril/valsartan plays a role, at least till you get to the higher end of ejection fraction, the normal or supernormal range. Maybe those patients won't benefit to the same extent. But I think your observations have been correct. There's a very quick improvement in quality of life when patients start taking sacubitril valsartan in particular.
Can you ascribe this RNA effects to any particular molecule like adrenomedulin or something like that? Neprilysin inhibitor means, is there anything? Because you have written a lot of articles regarding quality of happiness thing.
We don't know what it is that neprilysin inhibition makes go up. We know that a number of vasoactive proteins are increased when you take a neprilysin inhibitor, and this includes atrial natriuretic peptide, which probably plays an important role, BNP, CNP, adrenomedulin, endothelin. A number of things are affected by this. We're not entirely sure which it is. I think that there's some hint that atrial natriuretic peptide is playing an important role there, but we can't be 100% sure.
Professor, one question is there, I think. In which of the cardiac patient group we should avoid using SGLT2 inhibitors? That was the one question.
SGLT2 inhibitors have been proven now beneficial in virtually, some people are saying we should put it in the water. It's so useful because it's now been shown to reduce development of heart failure in patients with diabetes. It's been shown to prevent heart failure exacerbations in people with known heart failure with across the full spectrum of ejection fraction. And we don't know whether it would be beneficial in patients who don't have heart failure without diabetes. That's a group that's never actually been tested as of yet. We do know that patients with atherosclerotic disease, they may or may not benefit if they are at risk for heart failure. My guess is they probably would end up benefiting from these therapies, but this is a group that hasn't been robustly tested either outside of those with diabetes. With diabetes, I think it's very clear. So I think that there are very few groups of patients in whom we would be hesitant to use this if they have shown proven benefit already in clinical trials. So the patients without diabetes, without heart failure, there's no clear indication in that group of patients as of yet.
Is it euglycemic ketoacidosis, history of euglycemic ketoacidosis in a patient, type 1 diabetes mellitus?
Yeah, I mean, these are very rare events. And, we did not enroll type 1 diabetics in this patient in these trials. You have to be more careful. But I can tell you, I mean, we had only a few episodes of diabetic ketoacidosis in the entire dapagliflozin program.
Yeah, one more question. See, because as Vaduganathan, you have rightly said in HFrEF population, by using that fantastic 4 treatment, it reduces 6 years, it adds 6 years of life and 6 to 8 years of quality free from heart failure. So is there any comparison like triple therapy in HFrEF?
We've actually done some estimations and we published that last year. We have not updated that with the addition of now since the DELIVER trial, but we will be. I think at this point we would say that the two therapies that have evidence base and that are indicated in various places are SGLT2 inhibitors and sacubitril valsartan in some of those patients. And so we haven't actually done the math yet, but specifically, but I think you can extrapolate from some of our other publications. I mean, there is lifetime benefit, and we're talking really now not really about mortality benefit, but time free of heart failure.
One more question. See, because even with the triple therapy, there's a significant amount of residual risk is there in the HFpEF. So what is the role of diet or exercise, especially supervised exercise means sort of a rage in HFpEF right now. So what's your opinion regarding the role of exercise
It's a great question, and I would always say that there's a role of exercise in anyone with heart failure, and in HFpEF especially, because so many of those patients are obese. So many of them have other metabolic issues that exercise is likely to be beneficial. There have been a few trials, as you know, that have tested supervised exercise, and it does appear to improve a number of measures, including exercise capacity and tolerance in these patients. So I agree with you. I'm certainly telling my own patients with HFpEF that they should get as much exercise in addition to now the pharmacological options we have to offer them.
Means one more question, but I think the answer is obvious. If the ejection fraction is less than 40, are we justified in using all 4 modalities if patient tolerate?
Yeah, I think the answer is yes. I mean, for a patient with an EF less than 40, we should have them on an SGLT2 inhibitor. I believe sacubitril valsartan instead of an ACE or an ARB, mineralocorticoid receptor, and of course beta blockers. And now in some places, US in particular, it's been slow to get to get patients to be treated with MRAs, for example. We don't use as many MRAs as in other parts of the world. I think that we also have to convince our colleagues that we should be, if available and cost effective, we should be using sacubitril valsartan instead of ACE inhibitors or ARBs.
Yeah, continuing with questions. With the SGLT2 inhibitors, you said it is effective in non-diabetic heart failure population as well. So what I'm asking is this non-diabetic population, whether the glucose tolerance has been tested, because whether it is IGT or IFG, these patients, has it been tested in the non-diabetic heart failure patients, their glycemic status?
In patients without diabetes and heart failure, SGLT2 inhibitors benefit them the exact same amount as in patients with diabetes. And glycemic status is really not affected in these patients. I mean, there's a small hint of reduction in new onset diabetes in these patients. We're not sure if that's completely real or it's simply that you're simply having some effect on sugars. But the fact is that if your sugars are not high, these patients are mostly only spilling glucose when their glucose goes over a certain threshold. It's very interesting therapy in that it does benefit patients who don't have overt diabetes.
Yeah, because 3 eminent doctors are there as panelists or speakers. So Dr. Rajiv Agarwal, Dr. Andrea, Dr. Mayur. So are they having any questions to Professor Solomon?
I would like to ask one question. In our clinical practice, there are patients who are having a severe MR. Am I audible?
Yes.
Yeah, there are few patients. First of all, I think I should congratulate Professor Scott Solomon for delivering a very good lecture, and we are privileged to be standing with him today. And there are patients who are having severe mitral regurgitation. So what happens, they are more symptomatic and their systolic blood pressure is not very high actually. So then sometimes what I have seen is that this ARNI, we are not able to increase the dose. And here in these patients, the SGLT2 helps a lot because they usually require a good dose of diuretics because of their severe mitral regurgitation. So I have found out these are the toughest patients to manage, and all cannot afford the mitral clip or something, and they cannot afford the more destination therapies. So what is your experience of using? So sometimes then I use ACE inhibitor with SGLT2 or ARB with SGLT2 because the moment I give them ARNI, the blood pressure keeps on falling and the urea creatinine starts rising. So what is your experience?
Well, it's interesting. MR. Yeah, it's interesting because there has been at least one trial from Korea showing greater benefit with an SGLT2 inhibitor in patients with sacubitril/valsartan in patients with mitral regurgitation. And I'm not familiar with any randomized data with SGLT2 inhibitors in this setting, but I would say that if you can get your patient on a high dose of sacubitril/valsartan, then use the lowest dose, which is the 24-26 version. So a total of 50 milligrams, which that may give as much neprilysin inhibition as you need. To be honest, patients who can't tolerate being on an ACE inhibitor or ARB won't tolerate being on sacubitril/valsartan. But I've never had a patient who I've not been able to get on the lowest dose of a sacubitril/valsartan. You do have to sometimes back off on the diuretics, because if you have a patient who is over-diuresed, you're going to have trouble with sacubitril/valsartan or an ACE inhibitor or an ARB as well.
Yes, thanks.
Professor Solomon, you have said that in you have quoted the PROVE-HF trial that you are a part of the dose ranging studies of the sacubitril/valsartan. So whether they have got any survival advantage, it means different dosages of sacubitril/valsartan was tested in heart failure, and the lowest dose is equally as effective as the highest dose, like 24-26. That's a trial. I think you are part of a trial called PROVE-HF, I think.
Yeah.
So what is the survival advantage vis-a-vis lowest with highest? Means 24-26 versus 200.
So you can't say for sure from PROVE-HF, because remember, it was a single arm study, wasn't randomized. What we did see though is that there was significant reverse remodeling seen in that study, and we couldn't really assess survival in that study because it wasn't designed to do that. But there was a reduction in cardiac volumes and an improvement in ejection fraction. And there is a dose dependency, but I would say that we also could see that you get a substantial amount of NT-proBNP reduction, even with fairly low doses of the drug. So if you can't get your patients on the full highest dose of sacubitril/valsartan, then any dose is, I think, better than nothing.
As the professor said, because all of our heart failure patients should be on harney because it is a wonderful drug. So we have to be back off on the diuretics to make use of these fantastic four drugs. So one more final question from me. I think physician inertia or the therapeutic inertia is a major barrier for implementation of the Get With The Guidelines campaign or the GDMT campaign. Even in the Asian HF registry, right now, Indian set of patients are having only less than 5% of the patients are having GDMT. So what is your message for increasing solving the therapeutic inertia? Is there any new science that is happening in the field of this therapeutic inertia?
Yeah, I mean, we've been very interested in implementation of therapies that will get us to guidelines, and because, as you know, there's an enormous amount of inertia. We can put out guidelines, of course, but then they're rarely adopted in full force. So there are new approaches or new trials that are happening, new implementation endeavors that are looking at new ways to convince people. But the first part of it is what you're doing today, which is educating physicians and caregivers about the newer therapies. It took a long time for beta blockers to become standard of care in heart failure. It has taken a long time for sacubitril/valsartan to get substantial market share in heart failure. SGLT2 inhibitors should go a little bit faster, but we still need to go out there and educate our colleagues.
Okay, thank you. One more question from the chat box. I think spironolactone versus eplerenone versus finerenone. What's your comment in matter?
Yeah, I mean, spironolactone and eplerenone, there's good data in HFrEF for both of them, from the ROUSE trial, from the Emphasis trial. With finerenone, there is no data yet in heart failure. There's data in kidney disease so far. We're testing finerenone in the Fine Arts trial in heart failure with mildly reduced and preserved ejection fraction. Those data will be available in about a year and a half. We will see what that ends up showing. But at this point, I think for heart failure, we need to use some of the proven MRAs.
And one of the final question, I think this question you have already answered. Your comments on low dose of ARNI in patients with borderline BP that you have already answered.
Yeah.
I think. Thank you for your. Are there any more questions from panelists or any from the audience? So thank you, Professor Solomon, for an excellent overview and didactic discussion for the heart failure with preserved ejection fraction as well as the HFrEF. Thank you, sir, for your.
Take care. Bye-bye.
Yeah, bye-bye. Thank you. So now we are going to the presentation by Dr. Rajiv Agarwal. I think the presentation is titled Sacubitril Valsartan from a large clinical trial to clinical practice. I think my friend and senior colleague, Dr. Rajiv Agarwal, welcome to the presentation.
Thank you, Dr. Krishnan Kumar. I think we are left with 40 minutes, so I'll try to rush through and take on certain issues which had been discussed with Dr. Solomon. Dr. Solomon is the investigator, so it is very challenging to speak in front of an investigator. I am basically a clinician, not a researcher. So how I look at the data is my perspective, and I'm sure I'll drive home some couple of important points to the audience. This is a famous slide which I keep showing. This is Egyptian mythology, where your heart is weighed in the afterlife. If it is lighter than the weight of a feather of goddess Ma'at, you get to heaven. Otherwise, the Amit, which is a form of demon, it eats your heart. So a light heart, a small heart is always an advantage. If it is a large heart or a heavy heart or HFpEF, you are not safe even in afterlife in a lighter way. Whatever we are talking today is the research work of Dr. Adolfo Bold, who had been written a lot about, and I think RDs and all these issues is basically belongs to his fundamental research. And when I look at the issues of neurohumoral blockade, there are two types of responses to the stress myocardium: maladaptive response in terms of RAS activation, which we block by angiotensin II, and adaptive responses, which are secretion of nephrolysins. And what we have to do is reduce the breakdown of these nephrolysins by sacubitril so that both the arms become favorable. That is what is sacubitril valsartan is. Dr. Solomon is on the panel on Paradigm HF investigators. This is no opportunity to talk in detail, but I'll say it is a landmark trial, and whatever way you look at the data, everything is p-value being significant, and it is highly effective in reducing all-cause death and CV death. And if we don't take the comparison to ACE inhibitors, which was the trial design, if we compare RNI to imputed placebo, then NNT was just 11, and that is what is the power of RNI is. So you get another 20% benefit if you do inhibition. I'll answer one of the questions which was talked and discussed on panel. I try every bit of me to put patients on sacubitril valsartan so that we give them a mortality advantage over and above ACE-ARB. So I am yet to find a patient where I am using ACE-ARB and not able to use nephrolysin inhibition. There is a patient where I am not able to use any one of them. That is my perspective. So I have created a simple slide. The concept one is better together. Instead of saying dull things like 4 pillars, I say these are the Beatles' 4, fabulous 4. And once we know, we realize that the best outcome is with fabulous 4. Versiguat, omecamtiv, they come little later on. So you have to use fabulous 4 in every patient of HFrEF, provided the phenotype permits you. Whatever way you look at CV mortality and heart failure hospitalization or CV mortality, these fabulous 4 outperform any other combination existing in pharmacopoeia. And the beauty is all of them, they start working on within a month, and the risk of relative re-hospitalization, heart failure hospitalization is reduced by half. That is the power of RBs. They show benefit within 30 days, and it is safe to start in some patients in hospital RBs. The concept is better, which is touched by Dr. Solomon also, something is better than nothing. And that is the paradigm HF, which shows that patient who could use 100% target dose, 50 to 100%, and less than 50%, the relative risk reduction was same. And the explanation to my mind is patients who are not able to tolerate full dose, they are naturally sicker patients with very high event rates. Their phenotype does not permit full dose, and that's why 50% of the dose is as effective as 100% of the dose. I often repeat, don't take me wrong, I'm not asking that use underdose. Use the maximum permissible dose. If you're not able to achieve full dose, then don't get disheartened, because it comes the same way in terms of relative risk reduction. This is a South Korean study. Dr. Solomon talked about SGLT2. This is another South Korean study which talked about 25 milligram twice daily, and they found there is no difference in the benefit because these are very, very sick patients. So it is always something is better than nothing, and chase as much as you can do. And I often start, somehow I am very unhappy with the Indian pharmaceutical industry. They have not given us 25 milligram tablet, which is internationally available, to start low. Today, my algorithm is in borderline patient, I start quarter tablet twice a day, and most of the time I get away. This is another way to look at it, dose response with sacubitril/valsartan in HFrEF. And again, small dose, medium dose, full dose, you find the relative risk reduction is same, LVF improvement is same, pro-BNP reduction is same. So once again, a rider is, I'm not advocating low dosage. I'm advocating maximum possible tolerable doses. If they are low, don't get disheartened, because you will achieve the same. We had been talking and brought up with time is muscle. Why we don't apply to heart failure? I think that applies to heart failure as applies to coronary artery disease, acute coronary syndrome. Time to fabulous 4 of GADMT, time to target of fabulous 4 of GMT should be 2 metrics be considered in outcome, which at the moment is not being considered. So I'm a strong believer that from time to muscle, we should take inspiration to start these fabulous 4 as early and titrate them to maximum. You know, benefits are within 1 month. So these patients are very, very easily put on all these 4 within 1 month. This is the chronology that every drug shows benefit within first month. We have moved away from sequential to simultaneous. I think that is the biggest change we had been advocating from 21 onwards, that all these drugs should come together. They are not sequential, they are simultaneous. Then there is a very good study by Dr. Jund, which shows that if you do accelerated fabulous 4 induction, then you have additional 47% risk reduction, even in comparison to patients who had gradual vis-a-vis accelerated fabulous 4 induction, and it reflects 13% additional risk reduction in mortality and 47% heart failure hospitalization and CV death. So accelerated fabulous 4 induction is the issue today. We had been talking about reverse remodeling. I'll say reverse remodeling, mitral regurgitation, and antiarrhythmic effects are all clubbed together. When the ventricle is shortened, smaller, these patients do extremely well. They have, ARNIs have 20% risk reduction in sudden death and ventricular arrhythmia and ICD shock. The same thing when we look at the consensus, there was no difference on sudden death in solved trials. So this is a point which scores over ACE, ARB. This is a study from PROVE-HF, which shows that 32% patients after 6 months and 62% after 12 months will spill over beyond 35 and will no longer be candidate for ICD. So at the moment, guideline mandate of 90-day watchful is probably a shorter time if your patient is on ARNIs. I think we need to have a guideline revision on this aspect. Primary prevention ICD should be delayed if the patient is on ARNIs. And that's what it shows, that if all the patients, if patients are on all fabulous 4, the ICD and CRTD, they perform better. So they are complementary to each other. They are not competitive. This is again a PROVE heart failure, which shows the patient has got MR. These patients are ideal candidate. I often say circumvalsartan is a medical mitraclip. And if you see that from severe MR, it has gone to less patients in severe MR group. This is how you can make out that there is a redistribution of mitral regurgitation pattern after ARNI therapy at 1 year. So patients who have mitral regurgitation, I think we need more aggressive challenge to titrate these patients on ARNIs, because mitral regurgitation, because of positive remodeling, will decrease. And if you look at the positive remodeling, probably ARNIs are more powerful than SGLT2 inhibitors. This is about the positive aspect. This is about the negative aspect. Who are the patients who will not benefit? If they have very low EF, left ventricular mass index is high, heart failure duration is more, age is more, very high BNP and no change or less change in BNP, BMI is high, baseline and BNP is high. These are the patients who will not have improvement. So these are the patients who will probably go early for ICD vis-a-vis patients who are likely to show improvement. So we have to see that who are the patients who will not benefit. And these are some of the indicators picked up by artificial intelligence. Guidelines have been very, very aggressive in redefining themselves. European guidelines had been talking about 1P, but Americans have updated and they have changed the route. Instead of going through ARNI, ACE, ARB, now ARNI is being given as a direct slot for titration. So practically today in HFrEF, I do not find any patient who needs ACE, ARB, and we have to work on ARNIs as step 1. That is a consensus document. And in the same spirit, the AHA-ACC guidelines make it 1A. So all the fabulous favor has got 1A recommendation today. And that's why probably to my mind, ACE, ARB are no longer a drug to be used in HF patients. So are the Japanese guidelines. They have class 1 indication with level of evidence very, very strong. So these are the guidelines mandate that these patients should be treated as early as possible with ARNI, and how you judge your performance. This is a very good review article which talks about these quad scoring, QAAD quad scoring. And what is the beauty of quad scoring is that any dose on sacubitril valsartan is given 0.3. So don't be obsessed that if you are not achieving target dose, you are underperforming. I am once again repeating, I am not advocating at small dose, underdose. I am saying the maximum possible dose. So any dose of sacubitril valsartan is given 3 points, and you should chart your patient, your department should chart your patient, that how your department is performing on Fabulous 4. This is a very, very objective way to assess your performance. I think we need to put a time domain into this also, because time taken to GDMT, Fabulous 4 GDMT, and time taken to target GDMT, that is another time domain which is very detrimental for the outcome. I'm just towards the end of my presentation. This is Dr. Rita, who talked about days to life and life to days, meaning thereby quality of life and quantity of life, and no better drug than ARNIs, who give us another about 1.4 years of life if it is being used in younger patient, and 1.3 if after 65. And of course, as the chairperson started, the quality of life, you feel younger by a decade. Once again, I'm repeating, this is quality of life, not quantity of life. Don't get confused that ARNIs improve life by quantitatively by 9 years. It's quality of life. You feel a decade earlier. The last slide is very imaginative. The smartwatches have changed our life in terms of atrial fibrillation. And this is Wall Street Journal last year. My daughter sent me, and they are smart toilets. They'll be talking about blood pressure, weight, SpO2, and heart rate. You can text it to your clinician through digital data. And I think that is the best way to titrate these drugs. And I feel this is some kind of innovative domiciliary monitoring, hemodynamic monitoring of a patient. And these devices are going to change the outcome in terms of patient-doctor interaction in today's words on telemedicine. I'll just end up that Fabulous 4 are really Fabulous 4. Don't make it complicated. Pluck it fast, pass it on to the community, and let us learn wisdom without developing hemorrhoids, because these are proven drugs. Only thing is the physician inertia is to be reduced. They should be empowered with confidence. They should be empowered with knowledge to use these drugs, because they increase quality and quantity of life. Thank you very much.
Thank you, Dr. Rajiv Agarwal. As usual, it is a very, very nice talk, and very means you have pointed out all the major points, and especially the paradigms, especially your repeated emphasis on this treating, even use ARNI in every context of HFrEF as early as possible, as fast as possible, in every context. I think that should be the message. That fantastic Fabulous 4 should be used in each of the HFrEF, and your concept of your suggestion of time to GDMT, the earlier the better, in hospital is the better, sequential means simultaneous initiation, these concepts, I think, right, it is nailed presentation, I think. So I think we are directly going to the next presentation. We will be having the Q&A sessions at the end of the 3 presentations. We are running short of time. I think next presenter, I think it is Dr. Mayu. Is it Dr. Anurag Sharma, or who is the next person? Dr. Sunil?
Dr. Anurag will be presenting next, sir.
Yeah, Dr. Anurag. Anurag, you are mute. Huh?
Yeah, I think now it's my turn. Maybe SGLT2, though I had to talk on SGLT2. Should I share the screen?
Yes, please. Yes.
Okay. Is it visible now?
Yes.
Hello, my slides are visible.
Yes.
Okay. Hello, everyone. And my talk is on redefining role of SGLT2 in heart failure. So we all know, I think, that what is heart failure universal definition and main focus endorsed by many heart failure societies. And main focus is defining heart failure with language that patients can understand. See, basically, universal definition means that there are symptoms and or signs of heart failure caused by a structural or functional cardiac abnormality, and then corroborated by at least one of the following. Either patients have elevated natriuretic peptide levels, or there is objective evidence of cardiogenic pulmonary or systemic congestion. So if these two are present, then the patient basically has heart failure. When heart failure is a progressive condition, people, they present with heart failure, then they present with recurrent heart failure, baseline heart failure risk, and then there is a residual heart failure risk, then worsening heart failure, then advanced heart failure, despite medical therapy, everything. So basically, the first phase is variable, and the next is 3 to 6 months when the patient initial diagnosis and treatment, and then again it's variable, initiation and titration of GDMT, ICD, CRT, revascularization, and many patients will be ischemic, and after revascularization, they may not have heart failure. But those patients who nothing can be done, or they have maybe dilated cardiomyopathy, and if they have any sort of valvular regurgitation or onset of CKD and other things with the precipitating factors, they keep on worsening. And after optimization, the whole therapy, if they are refractory or intolerant, then they are basically patients for heart transplantation or mechanical or circulatory support or other palliative care, depending upon their age and other comorbidity risk factors. It is characterized by repeated heart failure events, worsening heart failure. That is the main concern, and resulting in reduced cardiac function every time, because there will be some sort of ischemia, and every time fibrosis will happen, healing will take place. And these patients will keep on dilating their left ventricles and increasing their pulmonary pressures, increasing the right ventricle failure. So basically, every heart failure episode is basically making them going down towards their demise. And there is need for IV diuretics, and there will be some increase in their the decrease or their in GFR. There are two distinct mechanisms which culminate in one clinical presentation. One is the reduced EF, and other is the opposite, the preserved EF, and both can lead to the same sign and symptoms of heart failure. We have now a lot of novel therapies for the past maybe 5 to 10 years. We are seeing a lot of work is done in heart failure patients, and we are getting now a lot of newer medicines, and ARNI, ACE inhibitor or ARB, then beta blockers, diuretics, aldosterone antagonists, SGLT2 inhibitors, hydrazine isosorbide dinitrate, ibabradine, and now we have also got the vericiguat. Stages of heart failure. Stage A is basically the patients who are having hypertension, who are having CAD, diabetes. So you can prevent these prevention of CAD complications and reduce the heart failure onset, doing maybe the primary PCIs, preventing the damage of ischemia. And then these patients go to stage B, basically structural heart disease, no symptoms. And then C is prior or current symptoms. That is basically the patients who are already on drugs, and refractory, again, basically these patients. But these are the stages of heart failure. So the role of SGLT2 is actually across all the stages, and there are many effects of SGLT2. Though previously it was not known how it affects, because it is not only effective in now diabetics, but rather the hazard ratio is slightly better in the patients who are having non-diabetic patients of heart failure. So there are many direct and indirect actions of SGLT2 inhibitors. How basically they do is basically decrease. They also have RAS effect on the RAS, effect on the sympathetic nervous system, inflammation, and oxidative stress. So they basically decrease all these parameters, and ultimately, lead to also they lead to weight loss, they lead to decrease in the body mass, and they also improve the renal functions because of the tubular glomerular feedback and the free water loss. CV protection, there are a lot of proposed mechanisms, and few have been proved also. That is, one of them is natriuresis and reduction in interstitial edema. Then cardiac bioenergetics are improved, and there is inhibition of cardiac sodium hydrogen exchange enzyme, which also improves basically the cardiac bioenergetics. And renal function is improved, so cardiorenal physiology is better. And definitely there is a reduction in interstitial edema, which also leads to reduced preload, afterload, and LV wall stress is less. So there are a lot of these mechanisms where it is overall benefiting the cardiomyocytes, and there's a less fibrosis, and I think less connective tissue deposition, and that's how it's helping even with those patients in the remodeling also, and in those patients of preserved EF. So pathogenesis and therapeutic benefits in heart failure. As Dr. Agrawal has mentioned, very good slide. The starting slide was adaptive and maladaptive. So I think the neprilysin system was more towards beneficial system. And here, the SGLT2, why it is a great drug is because it is not directly acting on all these three systems, but still it is helping these patients of heart failure. Because this is the mechanism of this drug is, I think, more deeper than all these three mechanisms, because it is acting at a cellular level, I think, rather than more at the neurohormonal level. That is the SGLT2 is that's why it's an add-on. It's a beautiful drug, I feel, for the heart failure. Then I mean to say this is a mandatory drug. And we all know that beta blockers are reduced, MRI reduced, ARNI reduced the relative risk reduction. And this is a metabolic in disorders of, and SGLT2 is affecting it at a metabolism level, at the cellular level, where they are inhibiting these inflammatory markers and helping the heart. And if you look at the newer drugs, basically of the cell signal mechanism disturbance, where these ivabradine, ferriciguat, and ARNI is helping in these patients. So now across all the trials, and we have seen mainly two drugs being more studied. That is, one of them is empagliflozin and another is dapagliflozin. That across all the EF spectrum, preserved, reduced, and DAPA-HF and deliver also is basically normal to increase preserved EF. So we have seen that 29 to 31% reduction, relative reduction of hospitalization for heart failure in patient with and without type 2 diabetes. This was the first trial declared TIMI 58, which established basically dapagliflozin versus placebo that is non-inferior for reducing MACE events in patients with diabetes and high CV risk compared with placebo. And reduction in heart failure hospitalization was noted, but no increased risk of amputations. Then basically, this is dapagliflozin in patient with heart failure with reduced ejection fraction. Then another trial came, DAPA-HF, which also again CV death and worsening of heart failure event, and p-value was very significant, and number needed to treat was 21, which is almost comparable rather to ARNI and maybe better than beta blockers and MRAs. DAPA-HF summary of worsening heart failure events and death, that basically across all these CV death, heart failure hospitalization, urgent heart failure visit, CV death or heart failure hospitalization, death from any cause, dapagliflozin fared better than placebo. And if you look at all those patients who are having age more than 65, rather it was better effect, less than 65, than male and females across all the ethnic groups and geographic region. Rather, you would say that in Asian population, it was much better. The relative risk reduction or the hazard ratio, you can say, the much better. And EF also, if it is less and if it is more, but still it was better. And cross BMI and etiology, ischemic versus non-ischemic, and diabetes. No diabetes means slightly was better. And prior hospitalization, definitely it improves the rehospitalization rate. Primary composite outcome according to diabetes status, that already we have mentioned. This is just in another way to mention that despite diabetes or non-diabetes, it is faring better. Then came basically question, because we never had a very good drug for SGLT2 inhibitor for this preserved EF. Then multi-center randomized trial, and they have shown that 12 weeks of dapagliflozin treatment significantly improved patient-reported symptoms, physical limitations, and exercise function, as was well tolerated in chronic heart failure with preserved EF. So that further, the SGLT2 substantiates itself into the 4 pillars of heart failure with reduced EF therapy. Rather, according to the approach, it is to be started with beta blockers and SGLT2, and then later on MRA versus ARNI, or ARNI first and MRA later on. Guideline, I think this slide already has been shown previously also, that now is part of the starting of the therapy. So you have to start the strong drug like beta blocker and SGLT2 to start with, and then ARNI and MRA depending upon the patient's blood pressure and potassium and renal function, other things. This is again basically treatment logarithm for management of reduced EF. Initial standard therapy. So it has come into the first block only, initial step 1. So this is important. Then assess clinical factors for additional interventions. Basically, ivabradine if the heart rate is still high, despite everything, if the patient is recent heart failure or hospitalized, then very Siguat. Again, looking at the blood pressure thing, because main thing is the low blood pressure is the main thing in this drug also. And black patients, you consider the hydrazine and nitrates combination, and rate control, add digoxin. And if you think that these patients who have maybe requirement still of dyssynchrony and symptomatic, and if they have QRS is more prolonged and LBB is there, then you can still go with the CRT device. And otherwise, ICD is more for ischemic, and non-ischemic, there are a few subsets where you feel that these patients have maybe bad arrhythmias or wide QRS or IVCD. You can still focus and maybe offer them ICD. Thank you.
Thank you, Dr. Andrag, for a wonderful presentation. So I think because of the paucity of the time, we are directly going to invite Dr. Mayur. So over to Mayur for your presentation on SGLT2.
Yeah. Thank you very much. Good evening, everyone. I'll just start sharing the slides. My talk is really simple. I'm not talking about heart failure and all those things. I'm an endocrinologist. So is it the dapagliflozin the new normal therapy in diabetes? Should it be prescribed to everyone? What the guidelines says, what the data suggests, all those things I'm going to tell you. So this is a very basic slide. We know that the SGLT2, this acts via insulin independent mechanism. So it can be given with almost all the drug, including insulin. And not only glycemic effect, it has some other non-glycemic effect as well, and it does not causes much hypoglycemia. It decreases the blood pressure to the tune of 4 or 5 mHg. And due to its not only the glycosuria action, which is the main weight losing mechanism, there are other mechanisms as well by which this SGLT2 inhibitor causes weight loss. So the treatment of diabetes has evolved over time. Initially, it was just the glycemic control, that whatever medication you want to give, you can give. The sugars would be sugar should be okay. That is what was the initial thought. Then came the patient-centric approach. That means according to the patient, we titrated the medication. According to that, we made their targets. And then came the era of this glucocardio-renal centric, that those drugs should be at least, even not, if not protective, at least should be neutral. And now we are taking those medications which have protective effect on the renal and cardio parameters. And now the latest thing is about the pathophysiological, the cause. That is what we want to treat in diabetes. So this, everybody of you must have seen the Omnes Octet of DeFronzo, where the 8 basic pathophysiology has been shown here, the 8 basic mechanism. So I'm not going into all those details because of the lack of time, but the basic thing is not only the pancreas, where the glucagon and insulin has some role, liver, adipocyte, brain, muscle, all those things, and the incretin effect, all those play a mechanism in the diabetes pathophysiology. So we want to target this. If we combine the SGLT2 inhibitor with metformin, with any DPP4 or GLP-1, we can target all the 8 mechanisms. If we combine the metformin and SGLT2 inhibitor, then we would be targeting 6 out of the 8 mechanisms of this Omnis Octet. This SGLT2 inhibitor, we know that it works on the PCT, where it causes diuresis. It decreases the absorption of glucose and sodium. That is what the co-transporter it blocks. And all those cardiac and all those things have already been discussed. Renal parameters, all those things have been discussed. So the main effect is not only decreasing the hospitalization to heart failure, it decreases the cardiovascular mortality and decrease the renal events. And it is now even indicated in those patients who have CKD without diabetes or heart failure without diabetes, right? So 2014, it was approved just to treat diabetes. Then it was for hospitalization to heart failure. In 2020, it was for a reduced ejection fraction. In 2021, with even in those patients who have CKD without diabetes, it is approved. So this is from different trials. If you see, this data has been taken from the phase 3 trial. So the higher the BMI, more would be the weight loss with the SGLT2 inhibitor. Higher the HbA1c, more would be the reduction. But in general, if you see in most of the patient, it would be in the tune of 0.75 to 0.9 HbA1c. But again, the higher HbA1c can have a higher reduction with the this SGLT2 inhibitor, and it can be used as a monotherapy or as an add-on to metformin, sulfonylurea, or already those patients who are on the combination. It can just. Sorry. So it can be used in all those. And regarding blood pressure, it reduces to the tune of 4 to 5 mmHg. This is a 2-year study done on the drug-naive patient, where there were 4 arms, placebo against DAPA 2.5, DAPA 5, and DAPA 10. After 24 weeks, metformin was added in each arm, or approximately 70 patients were included. And you can see here the HbA1c reduction with DAPA 5 and 10 versus metformin, and that was a low dose metformin, 500 mg. That was significantly different in terms of HbA1c and fasting blood sugars and weight loss. And renal excretion, the 4th one was the glucose renal excretion, that would be obviously higher with the dapagliflozin. This is a 4-year study. This is basically extension of the phase 3 trial. Almost 400 patients are there in each arm. So if you see here, the HbA1c reduction that was non-significantly different between the glipizide versus the dapagliflozin. But important thing, if you see as a group, it was non-significantly different. But if you see the number of patients requiring a third drug, which was higher in the glipizide arm versus the dapagliflozin arm, and BP reduction was higher and weight reduction was higher with the dapagliflozin arm, with reduced risk of hypoglycemia. So the important take-home message from here is that the drug is acting, have a sustained effect over long term, and is as effective as sulfonylurea. So the basic concept which there was prior in mind, that sulfonylurea are more potent than these drugs. It's not like that. Then this is a DEPIC trial. This is for type 1 diabetes. Almost 250 patients were in each arm, DAPA 5 versus DAPA 10 versus placebo. All those patients were on insulin, obviously. Only those patients who had insulin initiation for more than 12 months, they were included in the trial. This was to show that with dapagliflozin, there was sustained reduction in the HbA1c without increased risk of decay, and their insulin requirement dose was lesser. Okay, so insulin requirement decreased over 1 year. So coming to the guideline, the last part, what the guideline says regarding what's the position of SGLT2 in the treatment algorithm. So if you see, I've compared all those guidelines. So AAC, again, this says that obviously first is the lifestyle modification, followed by if the patient has ASCVD established or risk factor or CKD, you can initiate, or you should initiate SGLT2 inhibitor, or else you can initiate metformin as that. And if the sugars are much higher, you can even initiate a dual therapy. That is, if the HbA1c more than 7.5, then you can initiate dual therapy or triple therapy. And if the HbA1c is more than 9%, you can even initiate insulin. That is what the AACE 2020 guidelines say. This is from the BMJ, where obviously the cardiovascular disease is established ASCVD or CKD, you have to initiate this. That's okay. Even now we're giving without diabetes, so no need to discuss. But those patients who are diabetic with more than 3 risk factor being age more than 60, male, Asian, family history, diabetes more than 6.5, smoking, hypertensive, dyslipidemia. If 3 or more than that are present, then an SGLT2 is suggested. And those patients whom they have both cardiovascular and this CKD in them, it is recommended SGLT2 inhibitor. Coming to the NICE guideline from the UK, that again says the first line therapy is obviously the diet and exercise, all those, right? Followed by metformin. And if the patient has cardiovascular risk or decreased kidney function, then SGLT2 inhibitor is what should be given. Or if the patient have higher ASCVD risk factor, they use the QRIS2 risk factor in the UK. So if it is more than 10%, then you have to use a SGLT2 inhibitor. Coming to the latest, sorry, I could not change the slide. Yeah. Coming to the latest guideline, this is from the ADA 2023. So here, if you see, they have recently shifted down the metformin in the algorithm. Now the first line is obviously lifestyle modification, and if the patient has ASCVD risk factor, which includes age more than 55, obesity, hypertension, smoking, dyslipidemia, and microalbuminuria. So most of your patient will fall in this category, because hypertension and obesity, most of your patient would be having. Okay, so if that is there, then you can initiate even as a monotherapy SGLT2 inhibitor or a GLP-1 receptor agonist with a pro-1 CV benefit. And if the sugars are still high, you should add the other. If the patient does not fall into this category, then you can either initiate this or metformin or all those, depending on the glycemic control. So the potency of the glycemic and all those things are written here. But important thing I would like to stress here, if the patient has already established ASCD, high risk, or heart failure or CKD, a recent change has also been made that the previously what we used to do is a SGLT2 inhibitor should be given only if the EGFR is more than 30. But if you see here, even in the guideline, they have changed recently this, they have made it 20. That's obviously from the EMPA kidney study, in which they have used up to 20, and in the DAPA CKD, they have used EGFR cutoff of 25. So that is what is changed in the recent guideline. So now you can initiate anyone who has more than EGFR of more than 20, you can initiate this drug, or you should initiate this drug if the patient has CKD diabetes. Okay, so this is again from the ESD. Again, the same thing. They say that if the patient, all those things what we have discussed, the same C for the ASCVD risk factor, and then you have to assess that, and then you have to initiate this drug. And the ESC guideline, again the same thing. If the patient are drug naive, you can initiate or you should initiate an SGLT2 inhibitor or a GLP-1 receptor agonist therapy if the patient have very high risk, CV risk, or target organ damage. Target organ damage means if the microalbuminuria is there, if the fundal changes are there, then the patient should be initiated this. Okay, or if there is LVH. So that's also a target organ damage. So thank you for your patient hearing. I believe I was on time.
Well, thank you, Dr. Mayur Agarwal, for an excellent and crisp presentation, short, crisp presentation. So you stick on to time. So I think the session is open for Q&A sessions. I think all the panelists. I think there's a question in the chat box. I think this is regarding opinion on the usage of DAPA in patients with PCOS. I think being an endocrinology topic, I think shall I direct to Mayur? What's your opinion regarding PCOS DAPA in patients on PCOS patients?
So see, it's still, if you see, SGLT2 are not approved as a weight loss medication, and even for the pre-diabetes, it is not approved. Those patients with pre-diabetes can be given pioglitazone and metformin. There are some conditions, although we are not going into much details. So I've taken both the question together. So in PCOS, if the patient is diabetic, then it's totally different. What I believe you're asking, like a PCOS, can they be given SGLT2 inhibitor directly? No. Without no.
And what is the take on usage of SGLT2 inhibitors in pre-diabetic patients? I think you have already answered that one. Okay, and I think another question is regarding the ARNI or the Fabulous 4. I think Ashish Chand Jain from Uttar Pradesh, Meerut, when starting Fabulous 4, only DAPA can be started in full dose of 10 milligram, while other 3 needs gradual titration. What out of 3 should be tried to achieve the maximum, as when one try to increase all 3, then patient does not tolerate, and generally low BP, especially postural drop, is common complaint, especially in patient with FRAF. I think that was beautifully delivered by Scott Solomon and I think Rajiv Agarwal. So I think Rajiv, you can initiate. You have beautifully summarized.
I'll say. I showed you the algorithm for accelerated GDMT Fabulous 4. If you see the bottom of that, I can send the article on request. I have the PDF. The SGLT2 inhibitor and MRAs, they are the simplest drugs and hemodynamically relatively unstable, not making the patient unstable. So I always say SGLT2 inhibitors are numero uno. They are number 1 drugs which can be started in every phenotype. And once the patient gets better, you need to work very fast in first month, maybe more frequently to bring all these 4. You can't call the patient every 2 weeks or 3 weeks. And we have, the Trivandrum Heart Failure Registry, that we have 30 to 40% rehospitalization rate. The rehospitalization rate is higher in patients who are not on GDMT. So that challenges us, that mandates us that we need to see these patients early. If renal functions are fine, any phenotype, SGLT2, MRA, they are my drug of choice, and then gradually I built up. And probably ARNIs, we have to learn to use them in low dose. Even the best of the trialists, if you look Emperor Reduce, if you look DAPA HF, even these trialists could not use it in more than 15% of their patients. So the paradigm HF is a hypertensive phenotype where they were tolerating enalapril 10 milligram BD, and then you can switch over to ARNIs. But when we are talking of HFrEF patients, they are the patients who have 110, 105, 100 systolic blood pressure. So I strongly object that initiating 50 milligram twice a day as step 1 drug is a reality, because these patients are very fragile. If they go into ARF shock, then it is a mess. So start very low, not low, very low, and keep going gradually. Majority of your patient, you'll be able to achieve something like 50 milligram twice a day. 100 milligram twice a day, that kind of thing. Hardly in dilated cardiomyopathy, this South Korean study which I showed, only 8% patient could achieve the target dose of 200 milligram twice a day, which is a realistic estimate. So start very low and keep going.
Thank you, Dr. Anji, for an excellent discussion on didactic lecture on this thing. I think Professor Solomon also delivered the same point. I think he hasn't seen a patient or means in all of his HFrEF patients, he was able to start ARNI, whether it is a very low dosage or because the other study also proved, HF also definitely proved that even with low dosage, if the patient cannot tolerate the high dosage, even with them, all the benefits are seen. But the bottom line or the punchline is that you should maximize the treatment as far as possible in all the patients. It is not the low dosage, it is the maximum tolerated dosage should be the mantra.
Yes. And you should not feel unhappy that I am not able to achieve the target.
Definitely. Points well taken. So I think, are there any more questions? I think we are running short of time.
I just want to end up the discussion. Your house is beautiful and you have to invite me when I am there, because last time when we met, you didn't invite me. It's a lovely house and you have to host me there.
Okay, thank you, sir. That's a Zoom wallpaper. Okay.
Compliment your wife. Compliment your wife. Don't accept my compliments, your hard work. So, madam needs to be complimented.
Okay, thank you. So, Swapnil, Mayur.
I think, sir, we can conclude the meeting with your permission.
Thank you. Thank you.
Dr.
Anurag, thank you, Dr. Anurag. Thank you, Dr. Mayur. Thank you, Dr. Krishna Kumar. It was pleasure and learning from you all. Thank you very much.
Dr. Anurag, any messages?
No, I think we have discussed everything, and last question was very well answered by Dr. Rajiv Agarwal. Most of the things, I think, but I will be slightly differing with Mayur that if there is a obese patient with pre-diabetes, I think we should not wait for the FDA guidelines. Medicine is all about your experience and putting the things in the right perspective. So I use SGLT2 in those patients who are obese, but they are pre-diabetes, And
I think that is a very wise thing to do, because there is no opportunity that you can harm the patient.
Yeah, because they will lose weight. Actually, they will start becoming better, because that's not actually, because it is basically also approved in the prevention of heart failure now. So it will be, I mean to say, beneficial.
One more thing that we haven't discussed is, I think nowadays, I think as we cardiologists use bempedoic acid a lot, and bempedoic acid increases uric acid. But the thing is that SGLT2 inhibitors decrease uric acid by a different mechanism. It decreases tendinoid apical membrane, that GLUT9 receptor increased along with the glucose, uric acid also goes. So in the atherosclerotic cardiovascular continuum, if there is high risk dyslipidemia is there and patients are on bempedoic acid, is wise to use, means simultaneous usage of SGLT2 inhibitors may decrease the hyperuricemia associated with this thing.
I'll just add on another drug which we are dealing with, hyperuricemia. Losartan is another ARB,
definitely,
which drastically reduced uric acid. So you have raised a very valid point. Hyperuricemia of bempedoic acid, SGLT2 is the combination.
One more thing, I think from the Fabulous 4, I think we have to have this right now. Vericiguat is coming, ivermectin is coming, and omecamtiv is coming. So we should say I'll disagree with you. They are not going to be beyond 2, class 2, B2. Yeah, that is true. So Fabulous 4 are class 1A drugs. They are fighting for their survival. And another problem with omecamtiv and Vericiguat is these patients were SGLT2 naive. So you do not know what you will achieve. So I won't club those drugs into Fabulous 4 club. That you continue to be the Beatles, great 4. But we can use the adage,
definitely.
Okay, thank you all. Thank you for a very wonderful and fabulous session. I think thank you, the audience, for a wonderful interaction. I think over to Mayur.
Sure, sir. So on behalf of Alchem team, Metabolics, so thank you so much to all three of our speakers, Dr. Rajiv sir, Dr. Mayur sir, and Dr. Anurag sir, for wonderful deliberations. And last but not the least, I would like to thank moderator Professor Dr. Krishna Kumar sir for moderating the session. Indeed, the session was very enlightening, and we could got some practical insights on management of patients of heart failure and diabetes. So again, once again, on behalf of Alchem team, we thank you all and have a wonderful evening ahead. Thank you so much. Good night.
Good night.
Good night. Thanks. Yeah.